Hello everyone, I'm Donna Levin, National Director of the Network for Public Health Law. It is my pleasure to welcome you on behalf of the network to the 2020 Public Health Law Virtual Summit, COVID-19 Response and Recovery. Thank you for joining us, and thanks to all of you in the field of public health working to protect communities across the country. We appreciate the support for this summit from RWJF, the CDC Foundation, and the de Beaumont Foundation, as well as the time and efforts of the plenary and session presenters. Session speakers include almost all of the authors who wrote the report Assessing Legal Responses to COVID-19. On behalf of the report's editorial committee, thank you to Scott Burris, Temple University, who led this effort, and to those authors for their real-time analysis and actionable recommendations. I want to recognize that this month marks the 10-year anniversary of the network. Our goal to empower communities to use public health law and policy for safer, healthier, stronger, and more equitable future for all Americans is realized by the tens of thousands of you who have connected with us throughout the last decade for assistance, information, resources, trainings, and conferences. In that spirit, the summit offers 20 concurrent sessions and 2 plenaries, as well as real-time technical assistance sessions today with network attorneys and networking opportunities following the closing plenary tomorrow. You will hear throughout this summit about the inequitable impact of the pandemic on communities of color, and although law and policy have been used to create and perpetuate these inequities, they can be a force for change in the arc towards health justice. In our opening plenary, health equity leaders will address these issues and share their visions for a path towards recovery. And now it is my pleasure to introduce Dawn Hunter, Deputy Director of the Network's Southeast region, who will facilitate the opening plenary on health equity in a pandemic. Thank you, Dawn.
Oh, well, good afternoon, everyone. I am excited to kick off the 2020 Virtual Public Health Law Summit with 2 dynamic professionals, Daniel Dawes and Charmaine Ruddock. We're here to talk about health equity in a pandemic because it's clear that things need to change, that communities of color are experiencing not just the worst health outcomes due to COVID-19, but also are experiencing greater housing, employment, education, and childcare impacts, erasing gains that have been made over the last decade. But we're also going to talk about what happens post-pandemic, because even when we are back to something that we might call normal, things still have to change. We have 33 authors here of the COVID Policy Playbook who are also going to talk about what needs to change and how to do it. We are all part of communities, at work, in cities and states, alumni groups, churches, sports leagues. Our hope is that you leave here ready and equipped with knowledge and strategies to make change in whatever community you are joining us from today. We're going to hear from Daniel Dawes first. Daniel is the Executive Director of the Satcher Health Leadership Institute at the Morehouse School of Medicine. He is the co-founder of the Health Equity Leadership and Exchange Network and leads a newly established Health Equity Task Force that serves as an advisory body of subject matter experts who are devoted to creating innovative strategies for eliminating health disparities and achieving health equity in response to the COVID-19 pandemic. One of the end goals of that project is the development of a comprehensive health equity data platform. Daniel is also a leading scholar on health reform efforts and is the author of 150 Years of Obamacare and the very recently released The Political Determinants of Health. Charmaine Ruddock will follow Daniel. Charmaine is the project director for Bronx Health Reach, a coalition of 70 community and faith-based organizations funded by the Centers for Disease Control and Prevention to address racial and ethnic health disparities, where she oversees community-based prevention initiatives and public policy efforts. Her key responsibilities include developing a community coalition, linking healthcare providers, community leaders, community-based organizations, and others in a joint community approach to address socio-medical determinants of health disparities. Charmaine has extensive experience in administering healthcare services to underserved communities, as well as in the design, development, and operation of managed care organizations. So, We're going to start first with Daniel talking to us about the forces that create and reinforce health inequities and how we can partner, build capacity, and create change in this political framework. Then Charmaine is going to share with us exactly how communities are creating change and why it's so important for communities to lead and drive efforts to achieve health equity. We will have a discussion after their remarks, and we're going to have time for Q&A. So if you have questions, please answer them in the chat box, which is on the screen to your right. I'll be monitoring that chat box. And I also encourage you to look at the polls tab to answer 7 short questions. You simply click vote and select a response. And you'll be able to see the results as participants answer them. And if you see something interesting, don't worry, we're going to get to the results right after these opening presentations. So now, please join me in giving a warm virtual welcome to Daniel Dawes, who's going to kick us off.
All right, well, good afternoon, everyone, and thank you so much, Dawn, for that really generous, very kind introduction. It is an honor to join you all today and discuss how we can move beyond simply nibbling around the problem of health inequities in the United States, right, and effectuate lasting change. So today we're going to look further upstream and understand how these inequities, right, were concretized into our structures, into our institutions, and into our communities. So again, let me thank the Network for Public Health Law for the invitation for this opportunity to address you. I'm so delighted to join my colleague and friend Charmaine Ruddock on this journey, and looking forward to taking questions as we move forward. Let me start by saying that for too long, we know that many racial and ethnic minorities and other vulnerable populations, marginalized groups in this country, have found themselves in a precarious situation, right? Their lives, their health have been hanging in the balance, literally, right, over generations. Many of them have been falling through the cracks of our health system, of our education and human services system, employment, healthcare, you name it. And we know that for many of these individuals, they struggle to live in a society that has intentionally erected barrier after barrier to weaken their bodies and hasten their deaths. For over 400 years, these groups have experienced inequities throughout the life course, from womb to tomb, right? Today, the inequities in health status and healthcare are widely documented. In fact, over 7,000 peer-reviewed journal articles have cited these inequities. We know when you look at today, many of the inequities from the past are still haunting us even today, right? Recently, studies published in JAMA and other respectable journals have stated that 75% of children have been dying from COVID-19, right? 75% of minority children have been dying from COVID. And each of these had at least one underlying condition. The most frequent cited was asthma and obesity. We know that Blacks accounted for more cases and deaths relative to their share of the population in 30 of 49 states reporting confirmed cases, and in 34 of the 44 states that were reporting deaths. We know that also recently that Black, Latinx, and American Indian, Alaska Native people were disproportionately hospitalized for COVID-19. And the list goes on, as we know. So today I wanted to start quickly with a story about Shalandra Rollins, a story that I think highlights, the incredible case to be made for why we must continue to push for health equity in America, and why, with the privilege and the power that each of us have, right, that we must use it to advance the cause. So it started with a headache in late March, then came the body aches. At first, Shalandra Rollins' doctor thought that it was the flu. By April 7th, 3 days after she was finally diagnosed with COVID-19, the 38-year-old teaching assistant who had 2 years earlier managed to beat the odds, having lacked health insurance during her life, working in low-paying jobs, experiencing limited access to care, right? Working hard to get that associate's degree, told her mom that she was feeling winded. She couldn't breathe. Within an hour, she was in an ambulance. She was conscious but struggling to breathe, bound for a hospital in Jackson, Mississippi. An hour later, she was pronounced dead. Shalandra Rollins, a mother too, she had a number of factors that put her at high risk of dying from COVID-19. Like her mother, she had diabetes. She was Black with a low salary job. To date, we've lost at least 38,000 Black lives to COVID-19. And the majority of these individuals had an underlying health condition. We know that the underlying factors such as cancer and asthma, heart disease, and other chronic diseases strike disproportionately within communities of color and lower socioeconomic status communities. And as a result, these communities experience a greater risk or are at greater risk of complications from COVID-19. The inequities that predate COVID didn't suddenly appear, right? Nor are they inapplicable. Minorities and other vulnerable people still contend with neighborhoods that are largely devoid of necessary health protective and health sustaining resources. And they still contend with political determinants or drivers that created, perpetuated, and exacerbated these health inequities. So we know that, racial and ethnic minorities and others, die disproportionately each year. And it's costing us over $300 billion in this country. But the one thing we must always remember is that in the United States, the nation's health is not an organic outcome. It is not. It is not a coincidence that certain groups of Americans experience higher premature death rates or poorer health outcomes. So why is this happening? Why? Today, we recognize that a variety of forces collectively impact our health and determine the quality and the extent of our lives on this earth, including these social and environmental and economic, behavioral health, healthcare, and genetic factors, right? It is true that air pollution, climate change, toxic waste sites, unclean water, lack of fresh fruits and vegetables, unsafe, unsecure, and unstable housing, poor quality education, inaccessible transportation, a lack of blue and green spaces, right, parks and other recreational areas, and other factors do play an outsized role in our overall health and well-being. They increase our stress, they expose us to harmful elements, and they limit our opportunities to thrive. Yes, these social determinants of health play an outsized role in these human-made pre-existing conditions, but underlying each one is a political determinant that we can no longer ignore. But too often we're stopping at the social drivers of inequities, failing to dig even further to see the depths of the problem and understand its root causes and distribution. And as a result, we're missing the link between the social determinants of health and their legal and political roots. So let me illustrate this quickly with a story, right? If you were to envision all of society sitting on the banks of a mighty river, fishing and finding nourishment in the resources that the river provides, the health inequities that we face are represented by the differences in the caliber and the quantity of fish we encounter. Some people have a bounty of hardy fish or healthy fish and vegetation to feed off of, while others only have small fish, no vegetation, or malnourished fish. Different people having access to different resources and different parts of the river represent the social determinants of health. Some people are located in a slower moving part of the river by no fault of their own. Others are located in more lush parts of the river and benefit because of such by specific decisions made on their behalf. These are the political determinants of health. Somewhere upstream, decisions were made to divert the river to benefit certain people and harm others, and decisions were made to place certain types of people on specific banks of the river while placing others elsewhere. So these upstream decisions have downstream impacts. And I think the pandemic demonstrates the inconvenient and harsh truth about the impact that social determinants of health have been having and how collectively these factors significantly contribute to our society's health inequities. It shows the compounding effect of political determinants over personal responsibility. Think about that for a minute, right? The compounding effect of political determinants over personal responsibility, because no matter how hard many African Americans, Native Americans, Alaska Natives, Native Hawaiians, Pacific Islander Americans, and others, right, try to act responsibly, there are structural, institutional, and interpersonal obstacles that have been hindering them. Beneath these communities' notice are political determinants that have been pulling and continue to pull strings that prevent them from achieving their optimal health and full potential. So when we look at it today, we know that COVID hasn't been striking all. It's no wonder, right? Because our economic and social policies have not been benefiting all equally. Our laws have not been applied equally. All of these variables, who gets tested, all the way to access to water, access to food, these are political determinants. So I want to talk about Shalandra for a moment again. Shalandra's story, in effect, highlights how one political determinant after another resulted in a continual tightening of a chokehold on her community, and the eventual disaster that brought to light the inequities plaguing it. High obesity rates, diabetes, maternal mortality, depression, and many other health issues can be firmly linked back to political action or inaction. By understanding the political determinants of health, their origins, their impact, and their interconnection with the social determinants of health, we will be better able to develop and implement actionable solutions to close the health gap. What Shalandra's story, in effect, shows us is that behind virtually every health disparity and subsequent death, especially during this time, there were specific and insidious political determinants of health that led to the person's premature death. So for a moment, I just want to paint another picture, a picture of the tree of health. Initially, you may notice this magnificent tree, the fruit, the individuals, or even the tombstones. But actually, this tree, this picture is far more representative of what our society currently has to offer some of its most vulnerable people. The tree represents society. You see, there have always been co-laborers in the fight for health equity. Many of you I know who are watching today are in fact co-laborers who have been working assiduously to tend to this tree. We have worked tirelessly to feed the tree evidence-based policies, programs, and practices with the hope that the tree would provide fruit that would benefit all of society. However, the reality is that there have been others who've been working even harder, right? Overtime to supply the tree with that which would do it harm. These are the roots that are undergirded by racism, classism, and many other deleterious motives. From the bottom of the tree's base, all the way up and through to the ends of its branches, what is supplied to the tree is eventually multiplied by the tree. So now, due to the root causes of inequities, the fruit represents higher rates of diabetes, inaccessible, safe, and secure housing, a lack of nutritious food, and any other number of those outcomes that we know as the social determinants of health. And as that poisonous and sometimes rotted fruit falls to the ground, the tree that had the potential to provide life-giving nourishment to all who encountered it now only leaves death and destruction in its shadow from one generation to the next. But here's some hope. Now I want you to imagine, right, what could and should have been. The roots of the tree, which anchors the tree and is supposed to absorb nutrients from the soil, represent the political determinants of health. And the detrimental factors that the tree's roots were absorbing include racism, sexism, classism, homophobia, and many other evils. Every political and policy decision that is made feeds into the tree, yielding fruit which permeates throughout our society. But if the tree of health is rooted in health equity, the end result is a society that is nourished, cared for, and capable of achieving its full potential. Shalandra's story is not just a truly tragic story. It is a reminder that her death was not only preventable, but downright avoidable if only she had been fed by a tree of health that bore life-sustaining fruit. So this begs the question, how did we get here? We know that inequality gets under our skin, and it leads to accelerated aging or biological weathering, as Dr. Arlene Geronimus at the University of Michigan has coined, right? And it increases our rates of chronic diseases, as other researchers have noted. So think about it this way, a constant drip of water hitting a cement block. At first, you may not see the impact of that drip of water on the block, but over time, it wears away at the cement. That's essentially what is happening into African Americans and indigenous and other people of color's bodies, right? If you were to examine the DNA and the ends of the DNA, the telomeres, what they've been shown is that there's accelerated aging in these groups, and it's leading to intergenerational trauma. We know then that laws and policies have been an instigator in fueling and creating and exacerbating and perpetuating these inequities. You can go back 401 years to the time when Massachusetts became the first colony, not only to legalize slavery, but then all these other colonies followed suit, right? Where they also developed and implemented laws prohibiting slaves and indigenous populations from being able to address their social needs. They created laws that prohibited slaves and others from raising their own food, right? Growing their own vegetables and livestock, earning money, actually learning how to read and write and speak English, right? They prohibit them from congregating, from socializing in large numbers, having to carry passes if they wanted to do so in the community, or lanterns at night. And we saw these laws being recycled from one century to the next, from one generation to the next, right? And of course, as this country wised up and as the health equity advocates pushed back on many of these racist laws, you know, our opponents of health equity got smarter and moved away from facially discriminatory policies to facially neutral, right? But still having this detrimentally or disparate impact on communities of color. We now, when you look at the very communities, Black communities especially, across the United States, whether you're in Omaha, Nebraska, Overtown, Miami, Atlanta, Georgia, Boston, Baltimore, New York, New Orleans, you name it, wherever you are, you'll oftentimes notice there's this major highway that cuts right through these Black neighborhoods, right? Splitting this neighborhood in half. If you look at these communities, you'll oftentimes see parking lots abutting these communities, where housing once stood in these communities for Black folks. You'll often find bus depots that are disproportionately located in these communities, right? And what does the research tell us? No wonder Black and brown folks have higher rates of asthma in this country. They're breathing in more polluted air. But the question we need to be asking is, how did these infrastructure get there in the first place? Well, it's because of federal, state, and local policies. Federal laws like the Highway Act, the Housing Act, which created the Urban Renewal Program, right? And a host of others, the Homeowners Loan Corporation Act that redlined us intentionally. And over time, this led to higher payments, a poverty tax essentially on these communities, leading to higher payments for auto insurance or mortgage loans. It led to the deserts that we find in these communities, right? Food, pharmacy, hospital deserts, making it more difficult for these communities to access the resources that they need to thrive. And now we're moving from redlining to blue lining in these communities, right? In the form of climate gentrification and climate migration, where we're displacing minorities as a result. We see the impact of these redlining efforts over time. And if you overlay these maps, right, whether they're the big P policy or little P policy maps, over time, it's no wonder we see the same result, right? We see the manifestation of years of social and political determinants of health and the impact it's having on our life expectancy. We also know in closing that many of these laws, these policies have been the driving force for many of the health inequities, and it's going to take our collective effort to take an equity lens to these past laws and also to develop laws moving forward that will help us address that. As I close, I just want to leave 5 things that I believe we can do to elevate health equity in America. So the good news is that structural barriers, right, and the resulting inequities are not permanent, but it will take greater action from all of us. First, I would advise us to engage in these tough conversations around race, place, and class, and advocate for a full commitment to tackling health inequities upstream in all areas. Working upstream, right, to address the social and the political determinants of health inequities, understanding when they are at play. We also need to research the history of our communities. I think it's so easy to forget what has happened a generation ago, much less generations ago. But we must address the past policies and programs at all levels that created, perpetuated, and exacerbated these inequities, remembering that in this country, exclusion has always been easier to realize in policy than exclusion. Fourth, we must strengthen our networks and engagement. We've been weakened over time, and I think we've become complacent. We must strengthen them so folks understand that it's going to take continual engagement in this process to effect the changes you seek. It's not just about voting, but it's even beyond that, right? Although that is a critical political determinant. And lastly, the understanding that the political determinants of health, that understanding health equity begins and ends with the political determinants of health. Thank you so much. And Dawn, thank you for the extra time to finish this.
No problem. Thank you. And thanks for that great presentation. And so next we're going to have Charmaine talk to us about the community perspective and taking everything that Daniel just talked to us about and putting it into action at the community level.
So, hi, Dawn and Donna, I want to thank you very much for this invitation to talk about the Bronx. We talk about the equity inequity rather that the pandemic has laid bare, the grim statistics on how COVID-19 has affected communities of color. Nationwide, Blacks are dying at 2.5 times the rates of whites. The death rates per 100,000 people by race or ethnicity has been for Black or African Americans 87, American Indian, Alaska Native 56, Hispanic or Latinx 53, Asian 36, whites 36, Native Hawaiian, other Pacific Islanders 35. For New York and the Bronx, we were the epicenter for COVID-19, and the Bronx was the epicenter of the epicenter. In New York, to date, we've had 479,000 plus cases, more than 3,300,000 deaths. For the Bronx, we've had 50,000 cases, approximately 10% of New York's, and 5,000 deaths, reflective of 15% of New York's. The Bronx with the highest rates of coronavirus cases and hospitalization and deaths was in stark contrast to the mostly white and affluent borough Manhattan, which had the lowest rates. But even in the Bronx County, the only county in New York where the population is predominantly Latinx and Black, the 3 whitest zip codes in the Bronx around Pelham, Throgs Neck, and the Northeast Bronx showed among the lowest death rates in the borough. In a New York Times article back in May, the article was titled "How the Bronx Became New York's Virus Hotspot." The borough that had the highest rates of hospitalizations and COVID-19 deaths. The question that was posed, could more have been done? The answer was yes. More could have been done at the start, but more should have been done before the pandemic. The COVID-19 pandemic that basically devastated the Bronx, wiped out more than a decade of efforts to rebuild the Bronx with new developments and business, that has made life even more precarious for those already struggling to survive, including low-paid essential workers without health insurance, without paid sick time, and without unions to back them. But the COVID-19 that hit hardest in those African American and Latinx communities reflected the suffering of a high incidence of chronic health conditions like asthma and diabetes, heart disease, and obesity, to name a few, for years. Adults in the Bronx have the highest rates in the city of asthma, of diabetes, of high blood pressure. Obesity for adults, more than a third suffer from obesity and overweight. For children, they're almost 50% of our elementary age school-age children suffer from diabetes. The life expectancy rate in the Bronx is 5% less than Manhattan. The Bronx is ranked 62 out of New York State's 62 counties by the Robert Wood Johnson Foundation County Health Rankings report, and has consistently had that rank since the inception of the report more than a decade ago. Therefore, it should not be a surprise that the unhealthiest county also had the highest COVID-19 cases. Its ranking in health outcomes is also its ranking in the health factors contributing to those outcomes: health behaviors, socioeconomic status, environment, clinical care. In comparison to the other boroughs, where New York City is ranked number 6, Queens number 7, Brooklyn's Kings County number 15, Staten Island, Richmond County 21. As I said, the Bronx is 62. It should be noted that while the Bronx has remained 62, the Queens, Brooklyn, Kings County, and Staten Island have shown improvement year over year. So as a bit of a background, Bronx Health Reach. We're a 21-year-old community coalition of more than 80 organizations. We're led by the Institute for Family Health, a network of federally qualified health centers. The coalition was founded in 1999 as part of the Centers for Disease Control and Prevention's REACH initiative, and nationwide cornerstone address and eliminate racial and ethnic health disparities by funding the communities that are most experiencing those disparities to give them the resources to devise and implement their own community action plan. When we began working in the Bronx, we did a literature review, and we took it to about 10 focus groups from the community, and we asked them to respond to the findings, to respond to the diabetes that the literature review revealed. And the focus group themes that emerged was they battle racism in every sector of their life. Why should healthcare be any different? They felt disrespected by a healthcare system that treated them poorly and discriminates. There was a huge lack of trust in that system, a strong belief that they did not get the best in terms of quality healthcare, that if they were able to go a few zip codes into Manhattan, the healthcare system looked quite different from what they were experiencing. As a result of that, there was a fatalistic attitude to the care that they got. As one focus group member responded, "This is all I'm going to get, so just have to take it." So as a bit of a context, the socio and economic racial disparity of the Bronx is particularly telling, and why COVID-19 didn't so much as reveal, but just spotlighted. So in the Bronx is home to the nation's poorest congressional district. Of the 435 congressional districts, the poorest is in the Bronx. The median household income is $38,000 compared with $82,000 in Manhattan and about $61,000 citywide. The federal poverty level, 29% of the Bronx population is below the federal poverty level. And with COVID-19, the unemployment rate is 25% in New York history. But starting from the 70s in the Bronx, the history was one of redlining, lack of access to capital. In fact, we recently got the announcement that 2 banks just announced that they were leaving the Bronx, Chase and Amalgamated. Healthcare, we had for decades prior to the late 80s, early 90s, Medicaid mills that basically was a fraud system where most of our population that were on Medicaid received very little quality healthcare. In fact, many would say they didn't receive any healthcare through those Medicaid mills. We're a young borough. We're the only borough, as I may have mentioned earlier, where the minority is the majority population. Of the more than 1.4 million people in the Bronx, 85% are Hispanic or Black. Education. Where we have seen an improvement in education from 2010, we're now about 72% have a high school diploma. That compares poorly to the city where it's 82%. The share of residents with a bachelor degree or higher rose by about 1.5 percentage points since 2010 to 18%, but it's less than half the citywide share of 37%. With this backdrop, and with the fact that we continue to rank 62, the Bronx Health Reach Coalition, along with a number of other partners in the Bronx, one of our key health systems, Montefiore, the Bronx Borough President's Office, the local office of the New York City Department of Health, we got together and we launched a campaign in 2015 called Not 62, the Campaign for a Healthy Bronx. It was also that year that we won the Robert Wood Johnson Foundation Culture of Health Prize winner. We became the Robert Wood Johnson Culture of Health Prize winner. We have been trying to get the leadership in the city, the mayor, the borough president, even though the borough president was one of the initial participants in the campaign, to really talk about the kind of policies that the Bronx will need to remove ourselves from being 62. We had a meeting with Mayor de Blasio last November after trying for about 2+ years to have that meeting. And we shared with the mayor the Robert Wood Johnson County Health Rankings report. We shared with the mayor the health disparities that have plagued with the Bronx. We shared with the mayor the socioeconomic factors that continue to underpin the poor showing in the Bronx. And basically, what we said to the mayor, the contingency of us that met with him, is that the Bronx needs a Marshall Plan, one where it is clearly demonstrated that it has become a priority of his administration, as seen in budget allocation and agency priorities. We encouraged the mayor that in that Marshall Plan, some 3 of the key areas he should initially focus on was employment, affordable housing, and access to quality care. We reiterated to the mayor that the slogan for the Not 62 campaign for a healthy Bronx is that we can do better and we must do better. Of course, this was right before COVID-19 hit us. So what has COVID-19 spotlighted for us in the Bronx? We had the poorest testing levels of most of the city. Only now, over the last 2-3 months, have we seen an attempt to improve that with the Test and Trace initiative. With the New York City public schools being closed, one of the things that was particularly stark was the disparity when students had to go to remote learning, was a significant disparity in technology. A principal recently at the Bronx Health Reach Coalition meeting highlighted for us that she had the highest number of students living in shelters, but of the laptops and the iPads that were distributed, she only received about 60% in terms of the needs that met. She also pointed out the insufficiency in terms of Wi-Fi. One of the good things the city did was to turn all the laptops and the iPads that they distributed into hotspots, but it remains a significant insufficiency in terms of our students. Actually, the city controller, Scott Stringer, in a review of the digital divide and in a report issued last summer, found that 44% of New Yorkers in poverty lacked broadband access at home compared to 22% living above the federal poverty level. For many neighborhoods in the South Bronx in particular, that rate is between 43 and 48%. As I mentioned, COVID-19 really had an exacerbating effect on our unemployment rate. We're 25%. For food and COVID-19, the food systems that had already been identified for the Bronx as a place that not only had the highest rates of obesity, but had the highest rates of hunger. So for the food systems in the Bronx, we are particularly hard hit. For healthcare and COVID-19, I mentioned the testing. We now have the challenge that while there has been messaging around COVID-19 testing being free, we find that that's not actually so for a significant number of the population. Because so many of our healthcare provisions had to go to telemedicine, the digital divide exacerbated access to healthcare. The Bronx has 18 medically underserved areas. reflecting a combined population of 815,000. So having to go to telemedicine was a significant deficit for many of our Bronx residents. We've also had the challenge of segregated specialty care in academic medical institutions for poor patients, that is patients on Medicaid or those who are uninsured, and patients of color. Mental health. We have seen a real underreported issue of suicide and depression for many of Bronx residents. For many, housing and COVID-19 was an area of particular concern, because even though the governor and the mayor announced the moratorium on evictions, we now have added numbers to our homeless population. In closing, Bronx Health Reach has always determined that community participation and leadership is a principle by which we operate. And so many have been talking about the issues of disparity that COVID-19 has showcased. We wanted to hear from Bronx residents in particular. And so we did a survey. We had about 500 respondents. And we heard from them that their primary concerns was the COVID-19 testing and spread, the job insecurity, police interaction, mental health, and the reopening of schools. Many underlined as additional concerns how they didn't understand, didn't have access to technology, the lack of PPE supplies for them, the unavailability of that. And they were also concerned about how much information they were not getting that would help them to socially distance, get access to PPE equipment. So for the Bronx, we understand that not only have we had this history, but that the history has even made it more of a dire situation. And so the conversation that we're having is, how do we move forward? Thank you.
Thank you, Charmaine. And I wish we were in person and we could do a large round of applause for both of you for those excellent presentations. So I just, everyone who's watching, let's give a virtual round of applause. And we're going to dive right into some questions and discussion. So just as a reminder, I have seen a couple of questions in the chat box, but if you have questions, feel free to put them in. And I'm going to start out just talking about the polls. If you haven't seen it yet, you can go to the polls tab and vote. You can see the results live. So Daniel and Charmaine, so two of the questions that we asked were, I have a clear understanding of the social determinants of health, and I have a basic understanding of concepts related to racial equity. So actually, more than 95% of people agree or strongly agree with both of those statements, which is great news. But we also know that we often work with structures, institutions, and communities where there isn't an understanding, where we're not operating from the same definitions. What are your thoughts on what that means and how we work toward a common understanding as foundational for doing this work? Either one of you.
Well, Charmaine, did you want to go first, or?
No, go ahead, Daniel. Go ahead.
So I think you're right. Definitions matter. And I think what we have seen is over time, there have been folks who will interpret social determinants of health one way, right, to create nefarious policies, such as work requirements for the Medicaid program. And those of us who may adopt a different viewpoint, one that is in alignment with the World Health Organization's definition, right? Same thing with health equity. And it's a discussion I've been having with folks lately about what does this mean, right? And how do you articulate it in a manner that folks can readily understand and use, especially for those who are in positions of power who may not necessarily, like that idea of conceding some of that power, right? And offering additional resources to these communities that have long been excluded. So I do think you're right about definitions matter. It's one of the reasons why I created a definition even for the political determinants of health, right? So that we have a common understanding. There's a common framework from which we can, continue to expand on that conversation to get further upstream. Because if we don't, we will continue to merely nibble around the edges of the problem of health inequities in this country. So I do agree with you on that piece. Charmaine, do you have anything you wanted to add?
So I mentioned our meeting with the mayor, and I remember a couple of years ago, there was a town hall meeting where the mayor was there, and we raised the issue of the inequities, the reason why Bronx is 62 out of 62. And the mayor's response was that he was the mayor of the entire New York City, and so he had to think about how he shared resources, equally. And so I used what I thought was a more practical way to define inequity for the mayor. As a mother of 2 children, I pointed out that while I am responsible for the welfare of my 2 children, one child has needs that another child does not have as much need. And I thought particularly of my son, who needed more resources in terms of his education. And so I said, while I loved both children equally, as a parent, you allocate resources where the need is greatest. So I'm saying this to say that even with our policymakers and our elected officials, our decision makers, sometimes one has to help them understand definitions, help them understand in real and practical ways that it's hard for you to retreat from that or hide behind. Well, this is what I think it means. Well, this is what it means in its most simple form, in its most practical form. And so I think that was a lesson learned in terms of how to have common understanding of terms that we're using and things that we're presenting.
And Charmaine, I want to build on that because in your presentation, I noted that you talked about the importance of leadership and including equity and interventions that advance equity as part of the budget and clearly defined priorities in a plan that holds people accountable. So I wonder if you both could elaborate a little bit more on the importance of, what you said, allocating resources to this, making a dedicated plan and establishing accountability to the public to take actions that will actually reduce inequities.
So I want to respond to that, sort of first saying, and I mentioned it in my presentation, that the principle that we have abided by for Bronx Health Reach was a community-based participatory, the community leadership. And so that recommendation to the mayor, the identification of some of the key areas that we wanted him to first address and prioritize came out of the community. It wasn't something that Bronx Health Reach and its staff determined. This was community-based. And this was important for us to communicate that because we have to clearly recognize, and we have learned this lesson over the years, that constituents have the most powerful voice with elected officials. And this is particularly important for a community that's poor, for a community where the minority or the majority, right? Because the appreciation for the power is not always readily recognized by those decision makers. So we wanted to make that clear. When we spoke to the mayor, when we came to the mayor, we brought that in. And then the accountability is key, because one of the things, the unfortunate occurrences in the Bronx is that we have many of our elected officials, many of our policymakers, many of whom have been there for a significant amount of time, many of whom look like the community, somehow are not accountable to the community. And so one of the things that we've been doing is saying, you know what? let's start thinking about a report card. When you ran on this platform and people basically accepted and therefore supported you in the elections, well, when it now comes time for re-election, we're going to be holding up and determining where are you in terms of the issues that we deemed important, you said was important, and we supported you with our votes. So the report card is a critical piece of accountability. It's why we can go back to the mayor and say, these were the things we asked for. Please show us how you have moved on these things.
And just to add to Charmaine's point, right? In order to create this action plan, in order to allocate the resources, I think it's incumbent on us to understand, the systematic process for structuring relationships, for distributing the resources, for administering power, right? That we've had operating simultaneously throughout this country. And we really need to understand these, legal and political structures, the processes and the outputs that affect health. So in this country, it's been interesting when you are creating your action plan, based on the evidence, we've realized very few laws and policies that have taken an equity lens, very few that have been equity focused, right, in this country. And what we've noticed over time, though, is that the ones that have been successful have been the ones that have demonstrated the value of investing in change, right? So we have to understand the disquieting, that harsh truth that these legal, political determinants of health inequities have rarely been addressed unless their reduction or elimination served other purposes. So the ones that have been successful have actually realized that you have to be able to align that, right? You need to be able to show that there's an alignment with a commercial interest and a government investment value. Because if not, if you just make the moral argument, then I'm afraid that that roadmap is going to be quite difficult to achieve. And so there are principles, there are pieces that we've learned over time that have helped us to move that I think serve as a foundation for any advocacy effort in this respect.
So I think that gets to one of the questions that was in the chat box, which is, do we place more emphasis on pressuring state and federal policymakers? But then right after that, a question came in that I'm going to throw to you. We actually talked about this in preparing for the plenary, but what are some examples of more equitable and inclusive policies that we can either, advocate for as individuals, as part of our organizations, members of our community? What do those look like?
So I think the answer is an and. You pressure both. I do believe that in terms of what we've been able to achieve at that federal level, it's been because we've had, municipal governments, state governments, in fact, that have served as the incubators and given us some of the policy ideas that we could run with, that we could use then to push in federal policy and scale up the efforts in that local community nationally, right? So all similarly situated communities can thrive. So I would say it's definitely both. In terms of some of the policies, certainly, as I mentioned, there has been a dearth of these policies over time. We know that, depending on how comprehensive they are, it can put them at great risk. We saw that with the Freedmen's Bureau Act in 1863 to 1865, right, when that was being negotiated, and how contentious that was, right? Coming to modern history 150 years later, we tried to do something similar in creating a comprehensive health reform law. And again, you have the opponents of health equity constantly working overtime to dismantle it. So I think it's going to depend on how comprehensive it is. But I would look to the ACA as one of those. It's the most comprehensive, most inclusive health policy, taking an equity lens that we've been able to realize in this country post-Reconstruction. So something we can all be proud of. I think there are a host of other programs, the Medicaid, Medicare program, and others, that have been doing a great job in trying to elevate health equity, right? To the extent that our policymakers have allowed them to do so. So those are just a few I would highlight.
One example I would give from the Bronx, that while it has not yet found success, it's something that we initiated in the Bronx, and then we've heard, we looked across the country, saw what, and to determine what was happening in other places, and we've heard from others, and that is to address segregated care in academic medical institutions. This is something, you know, as I thought about your question, I was reminded that Tip O'Neill said, politics is local. And so you start something with some policies that are local to your community. And to Daniel's point, that they can be scaled up, right? There are other states that this is also a critical consideration. So in almost all states across the country, there is segregated care, segregated specialty care in terms of academic medical institutions. People who are poor, people who are on Medicaid, people who are uninsured, have a different avenue of care, particularly fellowship care, than those who are privately insured. That the facts support that. So we've had legislation introduced a few times in New York, but we also have to recognize that academic medical institutions and hospitals are very powerful. Even with policymakers that understand and appreciate that difference, appreciate that segregated care, it still is an uphill battle for that to be addressed through policy.
So I want to take a moment to acknowledge that we are at 12:57. We have about 3 minutes left in this, and there are lots of great questions in the chat box, and several of them relate to messaging. So there is actually a session on messaging if it's not already full. And there are also networking and Q&A sessions where you may get some questions answered, an opportunity to discuss more of like the difficulties of messaging in a political environment. One of the poll questions was related to racial equity tools, and it's the only one where it was majority disagree or strongly disagree. I have used a racial equity tool on a policy program or budget decisions. And there's, you also will have an opportunity to hear about those in other sessions. So I wanted to put that out there and then also turn it over to Daniel and Charmaine to say, you know, we wanted to kick this off with people, you know, understanding the importance of this conversation around the social and political determinants of health and health equity right now, but also what it's going to look like post-pandemic. What are some parting words that you have for attendees as they go through their sessions that you hope, you know, help to drive them to go forward and take action?
So I would love to make this point. It's the fact that, you know, today we are going through a triple pandemic. And the notion is that in a pandemic, with any pandemics that have struck the United States, we have never been able to realize an equitable response, right? An equitable policy response. And as we were, you know, trying to research why that was, you know, it's come down to the point that in many instances, data has been political. And we've not been able to get that data in real time to help align the resources then with the greatest needs, right? Some of that was intentional, others, you know, because of incompetencies and so forth. So as we entered 2020, and as this pandemic was striking us, we said, wait a second, our hypothesis is that the very communities that have been on the downside of advantage and opportunity from the very beginning until today are likely the most, the ones who are most likely being negatively impacted again, right? It's the same group of people over and over from 1793 when yellow fever struck Philadelphia all the way until today. And so if we know this, what are we going to do about it this time, right? With all the technological advancements, with all the skills, the knowledge and know-how, what are we going to do to stem the tide of this pandemic in these communities of color? And so one of the things I want to leave us with is the idea that health inequities, health injustices will continue to persist like they have for generations unless we seriously tackle the root causes or upstream factors, right? These political determinants of health. And I want to just leave us with a hopeful message from a dear mentor and friend, Dr. David Satcher, who was our 16th U.S. Surgeon General. And he says that, you know, ever more than before, we need people who care enough. They know enough. They've studied these issues, right? They have the courage to do enough, will speak up, against these injustices. And they will persist until the job is done. And I hope we have such individuals today viewing this session. So thank you again, Dawn. Thank you so much to Donna and to the entire team for the privilege of your time.
So I want to actually almost piggyback on what Daniel just said, using the name David Satcher, because it was under David Satcher's leadership that you had REACH initiated, right? And the genius of that was that the communities most affected were to be the cornerstone of any effort to eliminate racial and ethnic health disparities. And so, if you remember, I ended my presentation about recognizing our need to stop talking to communities, but actually going out and hearing from the communities what were the issues that they were confronted with as they were going through COVID-19. And so what I'd leave the attendees at this symposium is, don't just talk to each other, go out and talk to the communities that have been experiencing disparities. For many of those communities, COVID-19 is not a surprise. They quite understand that they have been living those underlying conditions, whether they were health, socioeconomic, etc. Go out there with the mindset and the respect that those communities are the experts. They have a real handle on what those disparities are, and that the collaboration and allyship that you build with them will really move us in the direction of finally realizing health equity.
Thank you. Yes, I agree with you both. And I would say, just to add to Charmaine's, is, make communities part of your political process. Not just, talk to them and have things happening in the community, but have, examples that Charmaine talked about, participatory political processes in place. So I want to thank Daniel and Charmaine. This was great, and I wish we had a lot more time to sit here and go through all the great questions that are coming in the chat box, but I promise you, if your question was not answered, there is an interactive breakout session where you're going to get some of these topics covered. So your next session should start at about 1:15. And we really appreciate your time today, and I hope that you have a great virtual conference. And again, thank you to Daniel and Charmaine for your time today. And thank you for the kickoff to the Virtual Public Health Law Summit 2020.
Thank you, Dawn.
Thank you, Dawn. Yep.